Hello, I'm Mason Clark. I'm 91, and I have had giant cell arteritis for almost 4 years. In 18 minutes, I want to tell you what I have experienced and what I may have learned. I'll be telling some controversial ideas about GCA and its treatment. Now I'll step aside and let you see the slides. I'll be back. I'm not a doctor, just a patient who has studied the medical literature and the experiences of others. Some of my opinions differ from accepted medical practice. You must work with your doctor. I have no responsibility for your care. And keep in mind that each patient is unique. My experience is not your experience. By the way, I have not had polymyalgia rheumatica, PMR. Many with GCA get PMR. Many with PMR will get GCA and should be wary of it. I know nothing about PMR. This story is GCA without PMR. There are many good sources of GCA information on the Internet. I'll give some good references at the end of this. There are two controversies in the treatment of GCA. One is caused by a misunderstanding of statistics. The other is a disagreement about the technique and objectives of treatment. One of my purposes today is to explain these disagreements. Giant cell arteritis is a grand nuisance. It need not shorten your life or keep you from doing whatever you do. You can see that I've been getting exercise during these years while hiking on the hilly trails of a local park. What is GCA, giant cell arteritis, also misleadingly known as temporal arteritis? Here is the College of Rheumatology's 5 criteria for diagnosing GCA. You have GCA, they say, if you have 3 of these 5. Notice that the minor surgery of a biopsy of the temporal artery may not be required. Doctors like to have it done for their record, but a negative result does not prove that you do not have GCA. If a large dose of prednisone gives relief of the symptoms in 1 or 2 days, this is strong confirmation of the GCA diagnosis, and it may have saved you from some loss of vision. On the other hand, if the prednisone does not relieve the symptoms, an alternative diagnosis must be considered. One of the early high-dose effects of prednisone is insomnia, which I managed by doing research during my 3 wide-awake hours of 1 a.m. to 4 a.m. This went on for only 3 or 4 weeks. The sleeping pill Ambien was not a solution, but I won't elaborate on that here. I acquired more than 400 files with comments, articles, abstracts, discussions, and a book or 2. The red book on top of the pile is entitled The Systemic Manifestations of Temporal Arteritis. So GCA is not just temporal, it is whole body, large artery arteritis. My obsession with information led to my writing my own webpage and a book. Both are free for you. Here are a few of the titles I collected. The Iowa article is a must-read for its treatment disagreement. Disagreement helps keep the mind alert. I can only give some brief remarks of what I have learned during these 4 years of computer research and my GCA experience. The detailed explanation of the arteritis and its treatment requires more pages of writing than can be given here. Here are some of the points you should know. A quick diagnosis can prevent GCA's serious symptom, loss of vision in one eye, by the quick use of a strong dose of prednisone. If in doubt about the diagnosis, there must be no delay in the use of prednisone. The rule is prednisone first, diagnosis later. A few days of prednisone, then stopped, does little or no harm. However, if GCA is confirmed and a program of prednisone is continued, the drug must be withdrawn slowly and with great care. It is a balancing act between damage to arteries by GCA and the many dangerous side effects of prednisone. The lying in the bushes waiting for a chance to attack is a dangerous adrenal crisis that simulates Addison's disease if prednisone is withdrawn too quickly. Regard it all as a game you must learn to play. It is important to understand that prednisone does not cure anything. It only acts to reduce inflammation. It is the inflammation that causes damage to arteries, restricting the flow of blood. Prednisone reduces the inflammation but has serious side effects. One of the side effects is a song.
Prednisone will make you get real fat. Prednisone will give you cataracts. Prednisone, it will destroy your bones. So take some prednisone.
Yes, there is a song about prednisone. This is just a sample from Carla Albrecht's song on YouTube. Search YouTube for prednisone, and while you are there, see Lisa Copen's giggle about the side effects of prednisone. Search Google for prednisone song and prednisone giggle. The prednisone itself does damage. What is necessary is a balance between GCA damage and prednisone side effects. The tests for this balance are symptoms and blood tests. The symptoms are many and variable. Each person is unique. Consult your doctor. There are two blood tests commonly used: sedimentation rate, ESR, and C-reactive proteins, CRP. Accurate treatment of GCA requires careful record keeping. A graph of the course of the arteritis inflammation and the prednisone treatment is really necessary to avoid overtreatment or insufficient treatment. My clinic provides this graph. It shows how my ESR varied over 4 years of having GCA. The laboratory signals the doctor if ESR is greater than 20. Without such a graph, it is difficult to manage prednisone. A diary of symptoms is also helpful and strongly advised. Here is a graph of my ESR and CRP over 4 years. CRP usually confirms ESR, might reveal a possible error, and is customarily measured along with ESR. An eminent specialist of the ophthalmology department of the University of Iowa has a strong opinion that only the blood test should be used to guide the prednisone dosage. This is based on much experience with GCA loss of vision. It is not the rule commonly given by rheumatologists who fear the damage of the many prednisone side effects.
Interested in giants of arteritis, I was at the Mayo Clinic, and they taught me a sentence which I think is most critical for you to know and for us to know. Namely, that the goal of therapy is to treat the patient and not to treat the laboratory. I think that is very important for everybody to know, because we are getting so used to looking at laboratory values, and then the question comes up, do we need to treat because the sedimentation rate has gone up? And the answer to that is, don't treat the sedimentation rate, treat the patient.
However, Dr. Hara of Iowa states, quote, a titration of the steroid dosage with the levels of ESR and CRP is the only safe and reliable method for tapering down and following up steroid therapy, and using clinical symptoms and signs of GCA as a guide often recommended by rheumatologists, is a dangerous practice to prevent blindness. This is the Iowa experience of prednisone withdrawal for 145 patients. Only 7 were offered prednisone in 1 or 2 years. Half were above 7 milligrams at 4 years. One woman needed 1 milligram for many years. Each tiny 1 milligram pill makes a difference. Many people cut 1 milligram pills in half to withdraw prednisone more slowly. This is the nature of hormones. Tiny amounts are important. ESR is very high before treatment, usually 50 or higher. After prednisone is used, ESR falls quickly, perhaps to the patient's normal healthy value. Among individuals, there is a wide range of healthy ESR and CRP. Healthy ESR ranges from about 2 to 30. Norwegians studied the ESR in 3,910 healthy individuals, mostly blood donors, and made the remark, knowledge of each person's baseline ESR value might increase the disease predictive ability of the test, unquote. In fact, this knowledge is essential in the use of ESR as a guide for treatment. The common error is to use for guidance the population data rather than the healthy normal for the patient. This normal is not known beforehand and can only be gleaned from the blood tests taken during successful treatment. Prednisone is a fire blanket to hold down the flames of arteritis inflammation. With too little prednisone, the flames burst through. In some articles, there is reference to patients who always have a normal ESR or for whom the ESR is never elevated. These authors almost certainly are misusing the population normal. A professor of medicine sent me this email. Dear Mason, I never saw an arteritis with a normal ESR or CRP in the last 59 years. Unquote. The confusion arises in misusing the term normal. Consider this statement about GCA patients from the medical literature. Quote, 10 of 177 patients had normal ESR values at diagnosis, equal or less than 30. Unquote. An ESR of 30 or even 15 is not normal for a patient whose ESR is less than 10 when they are in good health. The Norwegian study showed that half of elderly healthy people have an ESR of less than 10. An ESR of 4 would not be surprising, and for such a patient, an ESR of 15 would indicate inflammation. I'm sorry to go on about this, but it is important. This growing graph shows the history of my prednisone dosage in SED rate, ESR. No need to be neat, you can keep such a graph with pencil and paper. Before reciting my experience, let me admit that it is easy to know things with a 4-year record to view. It is much more difficult, if not impossible, to know what is right day by day as things happen. And keep in mind that your experience will not be the same as mine. My strong initial symptom, an atrocious right side headache, led to a diagnosis of GCA and a 60 milligram initial prednisone dosage. The headache was gone the following day. An ESR was 4 at the next test a month later. This suggests that my normal healthy ESR may be as low as 4. My ESR then trended upward as my prednisone was reduced. With only the slight warning of fleeting head pains, at 10 milligrams my ESR rose to 15 and 2 arteries above my right ear became swollen, one with a painful spot. This was scary because if the artery had been to my optic nerve and was so inflamed, vision loss in my right eye would have been likely. For me, my real but weak symptoms were not strong enough warnings. the rising ESR might have warned me. After a brief increase in prednisone, withdrawal was continued, with ESR tending upward. An ESR 36, high by any standard, led to an increase in prednisone, and again an attempt at withdrawal from 7 to 4. My legs feeling wooden and a rising ESR forced a return to 7, and again a slow withdrawal to 4, then an ESR flare of 40 forced another return to 7 milligrams. That is where I am now in January 2013. Notice that ESR may still be substantially above my personal normal, which I suspect is in the range of 4 to 7. Holding prednisone at 7 milligrams seems wise, awaiting a slow withdrawal. Ideally, with a smooth, slow withdrawal, flares would not occur and less total prednisone would be required. And be aware that ESR may be increased by other inflammations, a common cold or the flu or other infection. This can mislead one to take more prednisone than is needed. Each GCR or PMR patient is unique. Here are 8 graphs of GCA and PMR patients I have known, showing the wide variations in patterns of ESR and the prednisone dosage. Simplicity is rare. There are good sources of information and advice on the internet. Stick with reliable ones, such as the Mayo Clinic, Cleveland Clinic, Johns Hopkins, and the like. The Vasculitis Foundation has a long video presentation regarding large vessel vasculitis, GCA, on YouTube that you should watch. Search Google or YouTube using quotation marks VF Symposium 2010, Volume 05. However, Dr. Wynn begins with the controversial instruction, treat the patient, not the laboratory, that is standard in rheumatology practice. I've covered this in my diatribe here. Please do watch the VF Symposium YouTube. You may wish to see other outside-the-box data and knowledge from patient experiences. For this, I suggest you see 2 GCA PMR patient forums. A friendly place to share experience is the United Kingdom forum, PMR and GCA.forumup.co.uk. You will find there much friendly chatter. Look especially for a post by Eileen in the section Medication and Treatment. Look for the title, How Steroids Work in PMR, an easy-to-understand explanation. It applies to GCA as well. Use the forum's View Posts Since Last Visit to simplify your visits to that forum. Time spent exchanging experiences is well spent. Another forum of value is healthgroupsyahoo.com group Giant Cell Arteritis. There, watch especially for posts by James Rupp, who has done much research and continues to do so. He started me on getting knowledge of giant cell arteritis. Don't hesitate to ask questions and to contribute your experience to these forums. Again, let me emphasize, each patient is unique. My experience is not your experience. My website has more details of my own experience, and the 42-page book gives even more information and explanations. You can purchase the full-color, neatly bound book from Amazon, or on my GCA webpage, you can download it in Acrobat PDF format. Don't try to read the 42-page book on your computer screen. Print it, preferably in color. Remember these, and one more. GCA provides no excuse and not getting the exercise so important to health, and specifically to maintain bone strength against the attack of prednisone. EMR, with its many muscle pains, is another matter. I always feel better if I've been walking. On a recent hike in the hills, a young gentleman was reluctant to yield the path for me. He had a girlfriend nearby. Go for a hike and enjoy your GCA.